I hope you guys have been enjoying the conference. My name is Jonathon Feit, co-founder and CEO of Beyond Lucid Technologies. Some of you may have heard of us, some of you may not have heard of us. I'm not going to talk too much about our company right now, except to say that we are an electronic patient care documentation and pre-hospital health information exchange company. And relevant to this conversation, we were the first in the industry to certify and deploy NEMSIS version 3 technology. Not only in the field anywhere, but across state lines. So we have some experience, quite a bit, some bumps and bruises, as one might say, in going through the process of converting from one technology to another and deploying this new set of technology. So what I'm going to try to give you today, and it's really an honor and a pleasure to follow on Jay Fitch's conversation, is some context for what this new behemoth of information is. So with that, and I'm going to tie back to some of the things that he said in his last presentation, but as a show of hands, if I may, if I can, sort of assuming since you're here, but how many of you have heard of NEMSIS or are using an EPCR today? Great, so pretty much everybody. If you guys hadn't, I'd be particularly concerned. So glad. How many of you, I suppose, enjoy using patient care documentation, find it to be useful? Great, one. Is there anyone who feels, wonderful, is there anyone who feels that your paper records were more useful or more efficient than you have now? Great, so that's fantastic. And as sort of a last question, how many of you have a care facility, a hospital, some other regulator who is essentially asking for the information that you're capturing? And are you having challenges doing that? Are you finding that that has to do with your ability to hand off the information or of the care facility to receive it?
Oh, yeah.
Which one? Would you say, or both?
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 Yeah.
What electronic health record system?
Going down half the time, not maintaining.
Okay.
But corresponding and getting hurried in and out quickly, turnover. Hard. That's it. They're trying to be all caught up. But
Okay.
you understand the concept.
Great. So thank you. And the reason I asked this is because I really want to make sure in a fairly compressed time, I'm going to try to touch on a couple of different things here. One is, again, the why of patient care documentation, what it's supposed to do. But the other is, particularly when we talk about the connected ecosystem. If this doesn't work, I will do it right here. Let's see if that works. There we go. So one of the things that Jay talked about, and I wanted to make sure I noted, is this concept of disconnected, useless information. Probably because of the business that I'm in, I took a little bit personally last week or earlier this week, I don't even remember, when there was a conversation on one of the EMS management listservs about patient documentation and people decrying this technology as a waste of time, too much effort, information doesn't get looked at, doesn't go anywhere. And so we think to ourselves, as folks building these types of technologies, and there's obviously an industry of folks doing this, how can we make this useful? What is it that it ultimately needs to do and how does it need to work in order to get from useless, disconnected information to integrated, useful results? And I think that's really a mindset shift that is coming very quickly across the healthcare information technology ecosystem. So from your nursing home to your hospital to your doctor's office to EMS, and in whatever order you look at it, the focus on outcomes, the focus on what is the point of all of this is very important. And so this concept of connected emergency incident response, I wish I could say this came from me, but actually came from now former Chief Mike Metro of the LA County Fire Department, was the first person to phrase EMS 2020 to me in this framework, which is to say connecting the parts. And what does it mean to take this vision for the future and make it something we can do now? What technology do we have? What resources do we have at our disposal today? These zeros and ones that sit behind the software that you're using, paying for, hopefully at some level enjoying as an evolution, and make them useful today. And we've really boiled this down into 3 parts. One is, you got to make that information easy to capture. If it's too hard for people to use in the field, no one's going to use it. Obviously, one reason that folks like using iPad in the field, although there are significant technical limitations on iPad in an EMS environment, the fact that people are even interested in it suggests they've been hungering for quick and easy design. It's a sexy piece of equipment, and people understand that I can take it home and use it to play video games, and I can use it in the back of my ambulance. But really, it speaks to an underlying need, which is to say your technology needs to be fast. and easy to use, and to be able to capture information at the bedside. But at the same time, and especially when we talk about community paramedicine, mobile integrated health, now you really are at the bedside, possibly over and over and over again, and the need to capture that information. The next is to be able to make that information useful. So you got to be able to move that information. You got to be able to do it quickly enough that it can be that information can be handed off to medical direction, that it can be handed off to a regulator, whatever it is, in a surge environment. We were just talking about, an emergent environment like severe weather. You've got to be able to communicate. This is what EMS is made of, right? It's parts of an ecosystem coming together to do a very mission-critical, important job. And you got to be able to have the information go along with it, otherwise you're blind. And every node of that ecosystem is starting from scratch. That gets to the third bit. You got to be able to track this information. And so the movement, as Jay was talking about, the accountable care organization, the concept of connected health, is really getting to the heart of this idea that there are people coming back into your system over and over and over again in some cases. In my own county back in California, we have some patients that are being seen 8 times a day. We have a category called mega users, literally mega users. There's mega and super and frequent, and these folks are being seen over 300 times a year. So the idea that this information is in the system, and there's a ton of data around them, the sheer burden of having to do that over and over and over again and not hand that information off makes it seem really useful, or useless rather. But what if it didn't have to be useless? What if you could take all the information you're capturing at the patient's side or on the incident scene and hand it off to somebody else who needs to see that information eventually and would love to be able to have that information be useful, as opposed to feeling like, I'm not really going to care about this information, I'm going to throw away the piece of paper. So we looked at where that information is going to need to go, whether that's your medical direction, back to your agency for QA, onto a nursing home or a hospital, possibly even to a family member. One of the ways that I got into this business, and what keeps me in this very easy to navigate, totally unregulated, easy industry, is the fact that my father is a diabetic transplant patient who's had 3 transient ischemic events in about 2 years. And so he's in all sorts of registries. And I think to myself, if something were to happen to him, who do I want to know about it? Of course, I want EMS to be able to know what's going on. I want the hospital to know what's happened to him. But I really want my mother to know what's going on, because she's the one who's going to have the most insight about his health care, because he refuses to wear a medical bracelet and his wallet looks like something out of Seinfeld. So the idea that you could hand that information off in seconds is happening. I get notifications from Delta that my flight is delayed. Why can't I get this about my patient coming in? And we can do all of this today. And many of the systems you're already using today have the ability to do that. So what I'm trying to get to is help you understand what the value you can be asking for is, and that all that information can be handed off across your ecosystem if only you would ask for it. And that really puts a lot of the opportunity in your court and the onus on the vendors that you work with and that your ecosystem work with to do. So again, these 3 primary components, I'd be happy to go into each of these in more depth with you another time or later if you'd like, but hand off that information, be able to feed back that information for outcomes data, and be able to follow up on that information. So the next time you go out to that patient, you have at the ready all kinds of information you don't need to capture again and again and again and never see any benefit from it. So the idea is there are really multiple stakeholders in this, but all of them benefit. On the practitioner side in the field for things like mobile integrated health, community paramedicine, and your day-to-day job, the ability to analyze that information for syndrome mapping and surveillance across population health, and the ability to hand that off to the receiving facility, again, in near real time, so that your ecosystem as a whole can save money, save time, provide better care. That triple aim, again, that Jay was referring to. So we ask ourselves the question of why. Why is this even important? And again, I'm so glad to hear that everyone in this room seems to find some benefit to their electronic patient care records, but certainly not everybody is using them in the field. And this is one thing that we find to be a troubling trend. Again, it goes back to the concept of bringing good design into the field, because we still find that fewer than 50% of EMS providers across the country use technology for documentation in the ambulance. They may use it back at base. Their state may be providing an option for them to do that, but at the end of the day, there's still a piece of paper being written up. up. And in some cases, stacks of those pieces of paper that need to be digitized. That leads to all sorts of issues that I don't need to go into too detail for you guys, but everything from overtime to errors, the ability to, or inability to read handwriting off of that sheet because you've been filling this out while you were driving and something got smudged, or a paper got torn, or a piece of paper or a strip got left behind, and now you got to figure all that out. And we ask ourselves, in this day and age, why are we doing that still? So by focusing on the real business problems and you guys, what your needs are, rather than simply providing tools that work in a vacuum, that's where, again, the opportunity comes to you all to feed into your technology vendors what your actual needs are going to be. Which gets into NEMSIS 3 and hopefully why you should care about it. So what NEMSIS is, the National EMS Information System, is essentially the data structure of your patient care records. The transition from version 2 to version 3 has taken something like 10 years. May seem like it just got thrown on you and thrown on the industry, but it has not. It has been in a significant evolution. And if any of you are familiar with ICD-9 and the transition to ICD-10, it's about as big a process as that. And this is an enormous process that's transforming the nature of the information that you capture. In real terms, a NEMSIS v3 record is about double the size of a NEMSIS v2 record. And on the one hand, this is a very significant challenge because for any of you who are using a V2 system and will hopefully transition quickly to a V3 system, you're going to find the need to retrain your crews for sure. But there are some design challenges in how do you capture all that information without, as you said, sir, making this such a burden to do that it takes forever. And so again, there are paradigms for design that you should be going out and talking to your vendors about to say, look, we really need you to provide menus that are navigable, allow us to use tools like handwriting recognition that exist in other forms that are fairly new to EPCR, and let's use those because hospital-side data systems use these already, and they navigate through much larger data sets even than NEMSIS. And what this all comes down to is what Dr. Mann, who runs the NEMSIS project at the University of Utah, I'm just going to quote this, described as an incredibly important step that gives EMS equal footing in the health information exchange environment, to exchange patient information between EMS professionals and the health networks or waiting emergency department. And imagine, and this is your scenario, imagine if by the time you reach the emergency department, everything that is known about that patient who sits somewhere in your health system, whether recurringly or simply because they've gone to the doctor before, is already there waiting for you by the time you show up. And we can do that as an industry today, but there are some very important technical steps that need to be gone through. So, the key to all of this is something known as the continuity of care document. And if you take away one concept from today, it's the importance of this continuity of care document in the new world of health information technology for EMS. The continuity of care document is the way that electronic health record systems today communicate with one another. So nursing home to hospital to rehab to pharmacy and so on. It's essentially a subset of information. And that subset of information has to do with patient demographics, meds and allergies, past clinical visits, what you have observed in terms of your assessment, what you've done to treat the patient. It really has very little to do with a dispatch, because the dispatch is irrelevant to most of the healthcare system. It has to do with outcomes, but it doesn't really have to do with what kind of vehicle they were driving in, because that doesn't really matter. So what you find, and again, this point is very important as folks talk about interoperability, but you're doing this, but some of the folks doing the talking are not necessarily on the newest data system, and that's really important. Jay talked about obsolescence, and he talked about the evolution of systems and the fact that things, that what goes up sometimes comes down and things become stale. This concept of NEMSIS 2 is obsolete. NEMSIS 2 is as obsolete as 8-year-old CF-19s that some folks have been asking me about here the last couple of days. There are newer devices. Those newer devices exist for a reason, and even though they may be cheaper, there's probably some value in looking at what comes next. So this continuity of care document allows you to, in a streamlined fashion, make that evolution. The way that I analogize this is NEMSIS v2. Well, I tried to come up with some way of simply explaining this very complex technical architecture. And the thing that I came up with was the New York City skyline. There's lots of different data sets out there. Imagine that each one of those is a building. somewhere in the city, and it's holding people and information and all sorts of stuff. Well, in that analogy, NEMSIS 2 is kind of like the New York City Public Library. If any of you have been to New York, may have seen it. It's a square city block, and it's about 6 stories tall, and it holds information, and it's really old, and it does a great job, and it's survived wars and all sorts of stuff. But it's there, and it's not changing very much. It's also not particularly sexy, but it does the job. In that model, NEMSIS 3 would be like the Chrysler Building. It also takes up a square city block. It's big, and it's tall, and it's shiny, and you can see it from all around, but it's not the biggest. There are lots of other buildings around it as well that are really big, shiny, holding a lot of information in it. But this is an important enhancement beyond the library. It's got a capacity for a lot more. In this same analogy, something called HL7 would be the Freedom Tower. This is your gold standard. This is the electronic health records data backbone. And what the continuity of care document is intended to do is to map between what NEMSIS is doing and what the rest of the healthcare ecosystem is doing. The lines represent the common elements that go between there. Again, the fact that an assessment has been taken, that medications have been given, the demographics were captured, but it leaves out the components of that are going to be irrelevant to the rest of the healthcare system in a practical sense. If your electronic patient care record system is utilizing NEMSIS v3 and is able to hand off to you a continuity of care document, that is the subset that you are going to need to hand that off to Epic, to Cerner, athenahealth, Meditech, eClinicalWorks, take your pick, on the receiving side of your care, of your handoff exchange. That information can pass through in a fairly seamless format almost instantaneously. And that's incredibly important because there are companies out there in the marketplace talking about how to do this, but not being able to show how it's done or provide much specifics in terms of what they would need to do to evolve from their current system to one that can do this. And I want to caution everyone in this room and encourage, as you go towards NEMSIS v3, one of the probably the biggest takeaway of the value of NEMSIS v3 is the ability to do this handoff almost instantaneously. So when you go to NEMSIS version 3, and then you add on a couple elements, those elements in particular deal with mental health, past clinical visits, and family history. Those are, as folks in the room who are interested in community paramedicine will probably recognize, the stuff of community paramedicine. Post-discharge follow-up. Who are you over time? If you add those elements onto the NEMSIS v3 record, you get this interoperable freebie, so to speak, that you can hand off into almost any hospital's health record system operating in the United States today. So I know I've taken more than I was allotted for time. I apologize for that. I do just want to show you all my contact information in case anyone has specific technical questions on this. I also have some business cards I can hand out. But I do want to, again, just sort of underscoring the idea that this NEMSIS v3 journey that you guys are on has some very specific outputs. And those outputs will be helpful for the future of EMS, making EMS 2020 possible today. Even though it seems like a bit of a burden, probably a lot of a burden, the idea is that on the outside of that process, once you get through it, you're going to get a ton of ability to stand at the center of the emergency healthcare ecosystem, where you all belong, where you operate today, but don't necessarily get the recognition for it because the information about what you've done isn't handing off. Thank you very much for your time. I appreciate it. Apologize for going long, but I'd be happy to talk to you anymore afterwards. Thank you.